Good afternoon. I want to welcome everybody to this week's Power Hour. Today is an extremely important topic. We are a community in pain, and we need to come together and talk about this topic much more urgently. We are so thankful to our guests that we have with us today. We have Dr. Palmer Edwards, we have Dr. Bryant Murphy, we have Dr. Paul Cunningham, we have Dr. Karen Smith, we have Mr. George Pride, and we have Dr. Phil Brown. My name is Christina Natterdog, and I am here today together with my colleagues Albert Cuthbertson and Franklin Walker from the North Carolina Medical Society Foundation. And we want to thank our speakers and also our audience today. We had a record high number of participants, and that only shows us that I think we all share in the need to come together as a community and talk about this and take action, which is the most important thing. As always, the purpose with the Power Hours were started as a way to really focus on collaboration and focus on conversation, and above all, focus on community. And I think this huge gathering today is a testament to that we all are kind of having the same interest in that sense. Some of the logistics today. Since we have such a huge group, we're going to ask you all to be on mute. And if you have a question, we would like you to put that in the chat box, and we will take that out in the flow of the conversation. If there are any questions you feel we did not address, please feel free to reach out to myself, Aubrey, or Franklin, and we will put our email address in the chat box so that we can follow up with you, or you can follow up with us in terms of that question that you needed or wanted to address. I also just wanted to let you know that we are recording the session, and the recording will be available by midweek next week on the KIPL Institute for Physician Leadership landing page, which you can find under the Leadership Development tab on the North Carolina Medical Society webpage. As always, Franklin Walker is our moderator, and before I hand it over to Franklin, I would like us all to take a moment of silence in respect of the lives that we lost in the last few days. So please, let's take a moment of silence. Thank you very much for doing that together with us. And now I would like to hand it over to Franklin. Franklin?
Thank you, Tina, and thanks for the panelists, and thanks for all you folks joining us today. As you all know, the recent events in our country have once again exposed the inherent racism that exists in parts of society, including healthcare. And in today's conversation, we're going to touch on health equity and health disparities, physician workforce, and how COVID-19 disproportionately affects minorities. So the first topic I want to get into with the panel is about health equity, which is defined in giving everyone the opportunity to attain their highest level of health. Inequities are created when barriers prevent individuals and communities from accessing these conditions and reaching their full potential. Inequities do differ from health disparities, which are differences in health status between people related to social or demographic factors such as race, gender, income, or geographic region. Examples of health disparities in North Carolina can be infant mortality, diabetes mortality, and life expectancy. All of these tend to be worse for minorities. And what I'd like to do is ask the panel, why do you think this tends to be the case? And I'd like to start out with Dr. Karen Smith, please. Dr. Smith?
Yes. You know, it's a lot that we are seeing in regard to the disparities in care, particularly in North Carolina, and which is our discussion of today, but also across the country. And when we look at the existence of structural racism that has been present for years, long before many of our times, but unfortunately, those institutions that were created many years ago continues to exist. And when we speak of structural racism, we speak more of just an edifice. We speak of the behaviors. We speak of disenfranchised from the ability to obtain finances, housing, food, employment, and all of those factors come together and have an impact on health. And so I know we're going to speak more about that today, and I'll be love to hear what our other panelists would say about their thoughts on why is it that we continue to have disparities, and why is it's worse for minorities and the issues that we're having in our own state.
Dr. Cunningham?
It took me a while to unmute.
Okay.
My thoughts about this are not based on the data any longer. Data is convincing only to an intellectual. It does not seem to influence what I would consider the social priorities that we face. There's so many isms out there, all of which are, depending on your point of view, have potential damage and corrosive effects. But the psychosocial approach to how we deal with this particular ism, which is racism, that is because it's risen its head and has is gotten to a point in our national culture that it's attracting attention. So the question is this an opportunity for us to deal with this ism beyond all of the others that exist? And the question is then, how do we do that as a culture?
Thank you, sir. Dr. Murphy.
Yes, and I think that just to add on to what the Dr. Smith and Dr. Cunningham said, it's such a multifactorial problem that's really hard to pinpoint one particular thing, because everything is just so interwoven together. And so I think that whatever the solution is, it'll just require a lot of people coming together from a lot of different walks of life to kind of figure it out. But it's a very multifactorial problem.
All right. Dr. Brown, I want to get your take on it, because your background has New Hanover and health equity on it. And I love that.
Yes, sir. Thank you. I agree with everything that's been said. The interesting thing about it is we're trained as medical professionals to look at things in constellations. This is something that Dr. Cunningham taught me many years ago when both of us were much younger. So, you know, that we really are trained to look at things in constellations. And so as we peel that onion back on disparities and back to inequity, you know, there's a pretty clear constellation to look at. And it's plain and simple that this really is about long-standing systems of racial inequity, because the constellation cuts across every sector in our society. So as a very simple example, what is the difference between a law enforcement officer being able to look at and cognitively believe that they can treat an African-American male as something less than human, and a physician looking at a pregnant or laboring African-American female and look at her as less of a human and create different care systems? It has to do with the background that's been instilled into anyone on this call for their entire life. And it goes back much farther than that. This goes back to the history of our country. And at some point, if we really want to get at the heart of disparities, if we really want to handle inequity, then we got to understand that the Hippocratic Oath, as we've known it, is inadequate, woefully inadequate to the current situation. Because it says do no harm. our absence of action in the realm of race and race relations in this country has done tremendous harm. We no longer have the luxury of being able to stand somewhere in the middle and say, that doesn't apply to me, I don't think that way. We have to educate ourselves differently. We have to understand that to do nothing means that you support the systems of racism that exist today. And that to become an anti-racist requires a specific skill set that I would submit that every one of us who intends to deliver health and healing to the citizens of North Carolina or anywhere else needs to embrace that skill set. Otherwise, we'll be failing.
Thank you, sir. Dr. Edwards, I do want to turn to you because you're the only psychiatrist here on the call today and give you an opportunity to answer this same question, if you might.
I think from the psychiatrist's perspective, I think that these long established patterns in our society for the persons in minority or those that are discriminated against create a sense of despair as well as frustration. I think there's the frustration and now rage that we're seeing expressed more is somewhat predictable when you're feeling put upon and discriminated against and downtrodden. I think more insidious or equally bad is the feeling of I can't change the system, things are rigged against me, no one understands my plight, and so on. And so that in my practice breeds worse depression, more anxiety, and so on. And it's been a double hit the last 2 months with the COVID pandemic, already kind of setting the stage for a lot of emotional instability because of the great uncertainty that we all feel in terms of, are we going to get sick? If we get sick, are we going to die? What are my risk factors and so on? And then you throw in the health disparities and the discrimination, and it just it's really bad. For example, in my county, in Forsyth County, 54% of the persons with COVID-19 confirmed infections are Hispanic. And there are lots of reasons for that. As you all have probably tracked too, there's a disproportionate number of African Americans in North Carolina that have tested COVID positive too. And that's not because of any personal failing on someone's part, but there's a series of factors that contribute to these disproportionate showing. And again, that turns up in, I think, in despair, depression, anxiety, and then also the rage that we've seen in the last week.
All right. Okay. I want to keep going a little deeper on this one. The North Carolina Institute of Medicine recently released Healthy North Carolina 2030. I hope most of you all have seen that report, which provides a list of health indicators that as North Carolinians, we hope to adopt some of those and move those to improve over the next decade. I know that the Medical Society and our incoming president, Dr. Brown, have talked about adopting some of that report to be our guiding light for the next decade. I know myself as the executive director of the community practitioner program that we will put that in play starting at our fall meeting to guide some of the care paths for our community practitioners. But they talk about dismantling structural racism as one of those health indicators. And I'd like to hear from you all. We talked about maybe what some of those things were or are. Are there any tools that you guys can recommend to improve these indicators? And Dr. Brown, I'm going to start with you since I've already kind of dragged you into this.
Well, it starts with, like so many different things do, with the right relationships. These are, again, cross-sector initiatives that have to be dealt with in that manner. And I can give you an example of just one area where our medical center is working. So for 2021, we will have a system level report to the board goal around reducing the disparities in infant mortality. Now, we know that's really not a one-year goal, so we've got to put sub-goals under that that drive to it over time, just based on the law of numbers, right? But by putting things at the highest level of your organization, you can begin to deal with these things. I think another, how you begin to tackle these things is we create cross collaboration. Who benefits the most in the state by doing a better job eliminating disparities? It's clearly the employers. It's the only way to meaningfully reduce the cost of care across a whole population is to eliminate the disparities. Our problem right now is a willingness to turn a blind eye. And so for those of us who want to make an impact, what we have to do is keep it front and center. And that's why system level goals, bodacious plans on behalf of an organization like North Carolina Medical Society to come out and say, we think that if we follow this plan and reduce these disparities, that we can take North Carolina to a top 10 health ranking by 2030. That's how you get it done. We can't scrape around the edges of it. We have got to absolutely embrace it and work cross-sectionally with our schools, with all the different factions, and it's got to be done community by community.
I want to ask Dr. Bryant Murphy about this question because you sit in a very unique situation. You work with UNC in a big system, but you're also the president of the North Carolina Medical Board at this time. And I'd like to know if you guys as a medical board, Dr. Murphy, feel like there's some things that you could do to move this forward.
Well, I'll say that as the medical board, we're a little bit different in that, we're, a regulatory body. And so as such, don't specifically advocate or do those kind of things and haven't, met to specifically discuss this issue. I will say, though, that when we look at our mission statement, our vision statement, and the things that we do promote, and I actually just looked back at it this morning, the words that are in there are words like integrity, accountability, promoting inclusion, and being progressive. And, our goal is to ensure that the millions of patients in the state all have access to quality care. So those are the things that we are really advocating and pushing forward.
Super. I want to also ask Dr. Smith about this question because, again, you're kind of at a unique place because you're a rural, underserved area where you're practicing, and I'm wondering if you are familiar with the Healthy North Carolina 2030 and what you might be doing with that report to maybe integrate some of those things into your practice.
We are familiar with the Healthy North Carolina 2030 report, and the information from the report does move us to make a change, to make a difference. But in terms of solutions, one of the key things that all of us must do across all of our institutions, we need to communicate. And when we communicate, we need to make sure that we connect and connect with those individuals who we're working hard toward to make a change in their lives. I was so ecstatic yesterday when I received in my email Governor Cooper's order creating the Andrea Harris Social, Economic, Environmental, and Health Equity Task Force. And Dr. Brown spoke about starting from the top, starting from our leaders who we have elected, who are in place, who are paying attention to the people, who value people. And this is a great way to start, to show us by example what we can do open up the communication and connect with the people that we're serving, and remember to add value to each individual's life. And so that's what we're doing from our standpoint and the independent practice. But this is something that our state leader has initiated for all of us to be a part of.
I love your enthusiasm. That's so awesome. Mr. George, or Dr. George Pride, are you with us today? I don't see you up there, and I feel like I've left you out. There you are. Welcome, sir. I want to get to you on this question, but first I want to ask you about what you founded in Black Doctors USA. You founded this several years ago. I wish you'd tell us what motivated you to do that, and what were some of the goals that you set up when you first started this, and maybe some of the milestones that you've achieved so far.
I want to thank you all for having me here today. But the reason that I started Black Doctors, I started in Columbus, Ohio, and it's actually based upon what the topic is today, racism in healthcare. My mother has lupus, and she was going to one of the hospital systems in Ohio for her, her crisis that she's in. And she came home to me one day and said, son, I'm not respected. I'm not getting the questions answered that I'm posing. I'm not being respected. I think I need an African-American doctor that can help me more with my situation that I have versus what I'm experiencing now. And I said to my mom, let me find your doctor. And March 10th of 2010, I went online to do a search. And I was very deeply surprised that I couldn't find an African-American doctor online to help my mother with her lupus. By profession, I'm a marketing professional. I'm a marketing firm in Ohio, and I've been in business for over 25 years. And my mother, being who she is, gave me a threat. She says, well, since you're a marketing professional and a guru, why don't you create something for our community? I says, great, no threat from my mother. Let me go back to my firm and sit down and tell my team, this is what we're going to do. And we did our research and did development and found the NMA, National Medical Association, and met with Dr. George Bryant, who was the president of Ohio at that time, and said, here's my business model. This will eliminate some of the issues that we have in our community. This will allow us to be able to connect the community with the doctors and connect the doctors more so with the insurance companies, whether it's commercial or whether it's government. So Dr. Barnett took a look at it and says, all my doctors in my network in Ohio need to be a part of this. So thus we gave birth to Black Doctors Ohio, March 10th of 2010. When you look at what our goals are, it's to provide access to care. It's just that simple. You know, one of the things that we have an issue with is understanding how to go to a doctor, where to find a doctor, and what the heck insurance plan am I on? So our system has kind of eliminated that to where we now have an opportunity to where if an individual comes to our portal or one of our, platforms, all they have to do is basically put in information pertaining to who they are, their age, demographics, and insurance. And our matrix system will identify from where they live, the insurance plan they have, the doctors that are available in their network, in their area for them to go see. So, and based on how our system is structured, we can follow that patient from point A to point Z. So it's very unique, helping the doctors understand more about how to work with the PHPs and MCOs out there. Because I had a lot of questions, or should I say the doctors had a lot of questions to me coming in. George, we don't understand why we're getting such low reimbursements. Well, let me go talk to Tracy Davison, who was the president of United Healthcare Ohio at that point in time. And I says, let me figure out why the reimbursements are so low. And I gave my model to Tracy, and Tracy says, I want to partner with you. We need, why should I go out and try to accomplish or structure what you already have in place? So George, the African-American physicians that are within your network, I need them in my network. And what we can do, Tracy, is we can take your patients, refer them to our physicians to help everyone in the community and help everyone understand exactly what we need to do. So from that, this is one of the main reasons why I structured Black Doctors USA, is to be able to provide that bridge between the community, between the insurance providers, and also the doctors themselves. Because let's face it, it's communication. It's a lack of trust. And what we've created with, can we say, United Healthcare Ohio, with Tracy Davison and her group, is that co-branding opportunity to where we sit here and now our, can you say, brand is in the community and people are familiar with that brand. So now they know they can go to Black Doctors Ohio or North Carolina or Michigan or wherever and find that African-American healthcare provider. So with that said, when now you pair up a United Healthcare with our particular brand, it brings that trust. It kind of breaks down some of those barriers of not understanding what United Healthcare stands for. Or from a community perspective, here's an organization that is willing to partner with something that is specifically for us as our community, and they could care less about what the name is. It's an opportunity for this organization now to step forward and say, hey, we want to communicate at your level. We want to help you at your level. We're willing to do what it takes to necessarily improve the overall access to care. So that's a synopsis. If you want me to kind of go on with the achievements, Department of Medicaid for the state of Ohio came to me several years ago and said, we have an infant mortality issue. And I said, yes, I know. Based on the platform that we have structured, it allowed for those mothers with children under the age of 1 or actually ready to give birth access to those physicians to help them with their overall health care. It provided them the opportunity to be able to come to a particular place that made them comfortable to find the resources that they need to help them in their community, to help them at home, to help them with job opportunities and all that. So we took that and we moved the needle just a little bit. You know, it's a crisis that we're probably never, ever going to resolve, but it's one to where if we communicate appropriately and we put the necessary actions into place, we can move the needle everywhere, regardless of where we're at. Goals. The goals are just to continue to build the relationships like I have with Gibby Harris in Mecklenburg County, to where, you know, Ms. Harris came to me and said, I have an identity problem. People in Mecklenburg County does not know what we offer. They don't know who I am, George, let alone what we offer. Well, I have a solution for you. So taking and working with the government levels and working more with PHPs and working more with counties and states to help them understand how to communicate with the communities. And I'm not necessarily just talking about the African American community, but that is the topic. Communication. The problem that we have that I'm aware of in my journey through this is the lack of communication at the level that we're trying to give support. So if we can improve that, I know we would be successful in this arena. So that's kind of a synopsis. I can talk for the next hour and 49 seconds, and I know I don't have that much time. So, but that's kind of a synopsis of who we are and what we represent.
Well, I want to thank you. That's a really comprehensive answer, and we're probably going to have to schedule your own power hour for you just in July. So stand by. And I do want to ask you one couple follow-up questions, though. You've been operating, you said, for about 10 years now. How many states are you in?
We're in 4 states right now.
Okay, and how many total doctors are in your company?
We have roughly about 1,500 doctors that are within the network.
That's pretty impressive. Okay, I want to switch gears here just for a second. A few months ago, the Racial Equity Institute came over to the Medical Society and did a 2-day seminar with a lot of the staff and the board members, and some of the folks on the panel were actually there. This was really fascinating. And so one of the things we talked about was physician workforce, African-American physician workforce, and as it relates back to the last turn of the last century, and the Flexner Report, which happened in 1910, and following that, 5 of the 7 historically black medical schools closed. And then there were several other factors that contributed to the lack of training for African-American physicians. And presently, we've got about 4% of the physicians nationwide are African-Americans. So I want to ask you guys, why do you think this remains so low to this day, and what steps we might take to increase the level of African-American physicians in our workforce? And so, Dr. Cunningham, I want to come back to you for a shot at that question. Please, sir.
Let me quickly unmute. The fact is that we talked about what the Flexner Report did to historically black medical training facilities, and we're still recovering from that to a degree. So that is one factor that I'd like to put forward as being one of the underpinning reasons, foundational reasons why the pool of black doctors has not been as rich as would have been anticipated without some institutional systemic activity of the past. However, there is a much broader reason, in my opinion, and that really starts with our school systems, which are unequal in every sense. I certainly live in a part of North Carolina where our school systems in some counties are clearly not the same as the school systems in Charlotte. And to a great degree that is based on their economies, but their economies are also based on the economy of the African American and Latino and populations and Native American populations that exist within those communities. The tax base is not such to support those schools. And so you have teachers that are doing their best. They're also products of that community that are doing their best to cause their students to aspire, and their students likely may not aspire to become physicians at any great title. And I would contrast that with places that maybe have a different approach. Maybe, let's compare Windsor, North Carolina, Bertie County with Philadelphia. I would think that you could compare and contrast those two areas of the nation, and there would be stark differences in the societal structures that would lead to the ability to cause kids to want to become physicians. And so there's this broad foundation of lack of access, lack of aspiration that is not any one particular person's fault, but it's built into the system itself. And that, I think, will need to be thought through very carefully and overcome. Typically, however, whenever we have any of these complex problems, we start out as leaders with 3 thoughts in mind. First of all, and I'm going to present it in the usual priority. There is the fiscal component. How much money is it going to take to make a change? There's the strategic component. That is, what are the strategies and the tactics that we need to employ to make things improve? And then there are the generative components. That is, how imaginative and creative can we get in order to solve this problem that or seek the opportunity that we want in the most effective manner. typically we all get bogged down in the money part. So it's going to cost too much. We don't have enough money. And before you know it, we're all wrapped around the axle because we can't even start. The anticipation of spending money kills it before it actually is born. Perhaps we ought to change the way we look at things and start with the generative component. What is it that we can do in our medical schools? What is it that we can do in our high schools? What can we do in our grade schools that would make things better? Then let's create some strategies, and then let's argue about the money. So very complex, it's deep, it's been around for a long time, this issue of segregation in our culture, but perhaps we ought to start with the end point in view rather than begin squabbling about how difficult it's going to be.
Okay. Dr. Smith, Dr. Cunningham mentioned Philadelphia, which makes me think about where you went to medical school. So maybe you can take a whack at that question.
I would love to answer this question because I am a product of Washington, D.C. public school system. That's where I started. Many children, overcrowded, so many kids. How in the world were we going to get a decent education? But I can tell you every one of those teachers made it their business to make sure the children received the best education for what they had, for where they were. And as I went through my education, that was implanted in me, that I had to get a good education. And my grandmother and family, the family made it their business that I had to get a good education, and not me, all of the children. But it was interesting that as I moved through the education system, and as I entered Duke University, it was not the Black faculty, there were too few of them, who were not the greatest of support. It was the white faculty. It was a white faculty who saw something inside. But I can tell you, I went down to New Orleans and I spent time in the Tulane MedRep program, again, a program that was federally funded to encourage students to go to medical school. And it was in that program, for the first time in my life, I was told, you're not good enough to be a doctor. And I had to take that inside of me, and I made sure I am good enough to be a doctor, because I started off a long time ago and family put it in me and everybody else put it in me. I'm going to be a doctor. And then I went to Easton, Pennsylvania, where an older white surgeon said, you are going to be a great doctor. And you know, I call that the concept of fuzzy lines. And I had to get over what someone else had attributed to me, that I wasn't good enough, that I couldn't do something. And I had to determine what was inside of me, what were my true personal attributes inside of me that was going to make it work. And then I had to think about, well, how much of this is due to race? You know, how much of this is tokenism, that only a few can become a doctor, not all, 1, 2, but no more. And so we had to get over that. And so what I'm saying is that not all Black people support Black ways and Black people's missions, and not all white people support white people and white missions. We have a lot of people who are leaders who are in very much self-interest. But if we can just look for the gems, look for those kids who are interested in becoming doctors, give them support. Show them that they have value within them. Somebody did that for me. So we need to reach back and do that for somebody else. And we'll be surprised. We're going to have a whole lot of Black doctors, more than we could have expected, because we took the time to find the value that perhaps they didn't even see inside of themselves.
Super. George Pride, I want to come back to you. You're the lone non-physician, but my guess is you've got an interesting perspective on this. What do you think?
You know, when you look at the overall effect of mentorship, I think it starts there. I think we have to have more of the current doctors become more mentors. When I speak with a lot of the doctors now that are actually friends of mine across this country, that's the goal that they seem to have always attempted to start. But as it was mentioned earlier today, when you have funding that becomes a part of the equation, it seems that that's the stumbling block for everything to help the overall acceleration of helping the younger population become physicians. Once they become, or should I say, once they get that interest, it's like anything. I feel that if you steer a child or a person in the appropriate direction, and you have someone there that's mentoring them, the success ratio is very high. So for me, based on my experiences, I'm saying it's mentorship. We have to structure that in a manner that it makes sense for all of us. And as Karen said, I'll kind of echo that, you know, not all African-American physicians want to be mentors, and not all white physicians want to be mentors, but let's find those ones that do, and let's take that and motivate that and put a plan of action in place and inject that into our communities.
Thank you, sir. Okay. A few of you, I know Dr. Cunningham and Dr. Brown and Dr. Murphy had to get off to go to another engagement, but you guys work in systems, so you teach medical students and residents, and I'd like to discuss a little bit about what you all have done in your work to address inherent bias within the training of these young physicians. Dr. Brown, can you take that first?
Sure. Well, ours starts actually at an organizational level, not just a training paradigm. One of our key top 3 organizational goals is health equity. That starts with competence. And so for years, several years, we've done ongoing programs of cultural competency training to include not only just the trainees, but our entire staff, because we live in a pretty diverse place, and understanding how to create space to be able to listen to people is a big part of what that competency is all about. And it takes training and it takes practice. So really that's the main thing we do. We take it throughout the organization and have really decided that it's going to be a part of our DNA to treat people that way. We don't always get it right, but we always try. And we continue to get better because we continue to learn. And I think today gives sort of an example of how that plays out, because we've been doing this for a number of years now. But this morning we had, well, actually this week there was a lot of unrest, particularly in the residency programs around the racial injustice and what could they do to demonstrate solidarity. So we actually had one of our medical house staff officers came up with the idea. And so we did our 8 minutes and 46 seconds of white coats for lives in front of our hospital with dozens of medical providers, including residents, faculty, and independent physicians, and all kinds of staff. And to me, that demonstrates some of the success of the training that's been done over time, and also demonstrates the type of culture that says, if you feel a need, bring it forward and we can support it. So that's really how we've taken it. We don't believe whatsoever that it's something that we do. We believe it's something that we are. And that takes work, and that work you have to put in over time.
Super. Dr. Cunningham, can you speak to your experiences with this through ECU?
try to, sir, it's work in progress. There is no perfection. We're not living in heaven here. We're dealing with realities, and in my opinion, these realities will take some time, if not generations, in terms of the culture that we are seeing that causes health inequities. It starts with our mission. We're fortunate that we were given the mission by the state of North Carolina at the inception of the school that said we must recruit and matriculate minority physicians. It wasn't left to conjecture from the inception of the school. And people here in Greenville took that seriously. At East Carolina University, they really took that seriously. And so our performance is measured. We have to give a report to the UNC governing board and the legislature on a regular basis, and our effectiveness at recruiting minorities and matriculating them appropriately, not just sort of bringing them in and failing them, but allowing them to be successful is a measurement that we must produce on a graph and in tables that then become visible to everyone. But this work is accomplished through a number of steps. First of all, folks should be fired if they cannot recite the mission of our medical school on demand in any hallway at any time of day or night. So the mission of our school should be branded on everyone's heart here in Greenville. That is a sine qua non of keeping your job. The next is that there is continuous inculcation through propaganda, persuasion, any technique that you can ever imagine to make sure that our mission is living. It continues by recruiting the appropriate leadership. I think they made a mistake when they recruited the first minority dean at East Carolina University a couple of years ago. But I think it had an effect on the rest of the team. It seemed to have had an effect. But the most important thing is that the outcomes have to be measured. These are not platitudes. These are not hypotheticals. One has to measure the outcome of this activity on a regular basis, or it will lose its effectiveness.
Who was that dean, Dr. Cunningham?
I don't know, sir. I'd have to.
Oh, okay.
I'd have to Google him up. I don't know who it
Okay. Okay. Thank you. We know that during this time of COVID-19, it has impacted more disproportionately ethnicities than anyone else. In the U.S., there's accounts for about 13% of the population. In 24% of these cases, that we need to talk about, and how many people have died and why is that disproportionate? So Dr. Smith, can you take that?
The COVID-19 has made America wake up, and I'm hoping to make us change for the better. We have lost so many lives for reasons that we shouldn't have lost them. It had nothing to do, the COVID-19 disparities was not a genetic problem. It was not because of obesity. We had people who were essential workers who got up, got on a bus, got on a subway, and went to work to do services for the benefit of other people. And because of that, they were exposed to a virus that we didn't know a whole lot about, and they lost their lives. And so when we look at all of the social determinants of health, all of those factors surrounding why people were in a vulnerable situation and how they were exposed to the virus, if we can address those issues. So when we look at the percentages as a result of loss of life in infected persons with COVID-19, a lot of it does play out. It is social determinants of health. That was the key factor that keeps coming up in study after study. And then we have the underlying chronic disorders, the chronic diseases that had not been addressed properly. where people are still not controlled with diabetes and hypertension, where people do not have access to care. They don't have a doctor they can call their own, somebody they could pick up the phone and say, hey, I got a fever, I got a cough, I need help. And so we really need to address it. And my concern is if we don't address it, as our governor has already started to do, the second wave will be just as harmful as the first wave has been.
George, you've got a lot of doctors in several states. Can you add on to what Dr. Smith said?
I can. You know, it's truly the access to care. I mean, I can't, you know, my grandmother used to say all the time, you know, stop beating a dead dog with a stick. But unfortunately, that is the issue. It's access to care. It's having the ability to make sure that these individuals, that the communities that are suffering the most can reach out and understand how to reach out to a healthcare professional that can help them with the traumatic experience that they're going through. And if we can improve upon that, I know we would be a better society as a whole by providing that simple service. It's communication with access to care.
Right. Okay. Tina, I believe you've got a question.
Well, so I've been, you know, listening to all of you, and it's there's so many things. I think one thing that you know, obviously is very clear that this is a long problem that is systemic. We're talking, you know, in the racial equity workshop we did, we talked about the groundwater. We need to work on the groundwater, right, and change these systematic unjust or unfair structures. My question to you, I mean, and as I heard Dr. Cunningham talk about the school system not being native to this country, I've always been amazed that property taxes are tied to the schools, and you know, that should be something that we should work on to do away with some sort. But apart from that, I have a question to you, and it may be, we're coming up on time, so it may be a long question or a long answer that's required, but what are your thoughts around affirmative action? And I'm just going to leave that to anyone who feels that they have a thought around that, or, you know, want to take that on. And let me tell you why I asked this. I asked you this because sometimes, you know, you look to other countries, there's been some issues that have been managed to get ahead on by using affirmative action. And I know there's, like, you know, there's pros and cons with it, right? So it's a pretty aggressive way to try and force something. But I'm just wondering I would love to hear your thoughts on it.
Well, we've had white male affirmative action for 4 centuries. And so at some point we've got to figure out a way to do things differently. Exactly what that means and how you get there, I think has been the hurdle. But without a doubt, it all starts with intentionality, no matter what you're talking about. And so when you talk about affirmative action, that could mean a policy of affirmative action, or that could just mean a commitment to affirmative action on behalf of an organization, which is what we've done. You know, in the traditional sense of affirmative action, you know, that really didn't end up benefiting who it was intended to benefit. And that's the danger with policy, is that you get them almost right. And so to me, a lot of this stuff gets handled by individual decision makers committing to the higher ideals that we're talking about and effectively becoming forces of nature within their teams and their organizations to make it happen. And if we do that, we'll see change.
So Tina,
Yeah.
Paul Cunningham here, you kind of struck us dumb when you brought up the word affirmative action, because affirmative action has sometimes gotten the image of being just a bludgeon, like a baseball bat that's going to make stuff happen out there no matter what people really think. I'm going to put some money in the thing and it has no heart. It's even, I imagine the authors of this had really great intentions, but the way it's translated on the ground is that this thing is coming from somewhere outside above. It's in Washington, D.C., and we're going to do something to at least present ourselves as getting the job done. Meanwhile, some interpret that as being separate and unequal to separate and more equal. The busing thing came in there, and that was perhaps a part of it. So we're just going to mix some students up together, and maybe that will help. At the same time, we have two entirely distinct cultures, two entirely distinct economic engines, and I can feel it and see it. We bury our dead in Greenville in two different plots across the same street. I told my family that when I die, I want to be buried in the middle of the street, right on the white line, actually it's the yellow line. That's a better, more politically correct color. I need to be buried on the yellow line in the middle of the street. So this issue of racial inequity goes so deep that we may want to go to affirmative action version 10 with more heart, because it seems as if we've come a long way, but we still have a long, long way to go.
Yeah, and I think I totally, and I think with understanding, because I also think that there is so much understanding that needs to happen about just how deeply rooted and how complex this is. And I love what you're saying about the cultures, right? We need to understand our different cultures as well and come together as a unit. I might be overly democratic. I'm from Sweden. We're very democratic. We're all for, inclusion and being together and all that. But I personally feel that and I love what you're saying, we need to start with the end point in mind, right? So with that in mind, where do we move from here? Where do we go from here as a group and as a unity? So Dr. Smith, I see you raising your hand.
I did want to address the question, because the protesters of today, the protesting that we see is amazingly diverse. Mm. And they are pointing out that we are more similar than we are different. And they are pointing out that there's value to each one of us. When we saw George Floyd die with a knee on his neck, what I saw was almost the death of humanity. But what I saw rise up was humanity, was unconditional love. People came out to support our country and to support humanity. So I'm concerned when we go back to old solutions of the past, when we have generations of thought that will bring new ideas, and we have people are conceptualizing what we know of as culture is coming together as one. We're coming together unified. And I'm looking forward to what these students and young people and older people who are protesting with them will come out with new policies that's going to bring forth new legislation that we won't need affirmative action, because all policies will represent everyone without us having to demand numbers. Because at one point, the reentrenchment will occur and those numbers will go away and we will be back to where we are today. Now, I'm looking forward to a lot of great ideas on the horizon, because there are visions out there that we just can't even imagine right now.
And I love that, hope. I love that. And thank you for indulging me in my question. I know it was a little controversial, a little dumb, as Dr. Cunningham said, but I really wanted to hear your thoughts on it, and I appreciate it. And I thank you so much for that hope. I just feel that, you know, as a community, as a group, we can really be strong together. Franklin, I took a little bit too much time. I apologize.
No, not at all. I think the conversation has been wonderful, and we're at the top of the hour, and I was going to ask another question, but I think I'll end us on time. I do want to say that Dr. Edwards, who is our current president, sent a message out this week and sent a clear signal that the Medical Society is going to make health equity a central tenet of the Society's work moving forward. I want to applaud Dr. Edwards for that message, and I want to applaud my panelists today. You guys have been great in tackling a difficult subject. Thanks again, and we'll see you next week. Tina?
Thank you so much to everybody who's been listening in today. Thank you very, very much to our guests. We so appreciate you taking your time to be part of this very important topic, and the first of many conversations that we are to have. Please tune in to the Power Hour next week, and also visit the page, the Cunningham Institute for Physician Leadership page, where we will line up the topics that we have coming. And as you will see, we will have more conversations like this around this particular topic again. With that, I thank you all. This recording will be available to you next week. And thank you so much for everything that you do, and thank you for allowing us to serve you the best we can during this time and for the future in any way we can. Thank you.